You're listening to In Good Health, the trusted news source for medicine, science, and technology. I'm Elizabeth Westfield.
I'm Mayan Vasta Betancourt.
And I'm Greg Johnson. This week, why we can't rely on medical volunteers when airline passengers have a medical emergency.
Yes, it works in 80%, but it could be not ideal in a few cases because it could be, with all due respect, it could be a dermatologist.
But first, your doctor may be overlooking a condition that could be causing your infertility.
My endocrinologist, who's been in practice for over 30 years, said to me, "I've never seen anything like this. We've thrown the kitchen sink at you. I think you need to see a specialist."
All that and more this week on In Good Health. Lisa McCarty had been trying to get pregnant for years before deciding to see an endocrinologist who helped her begin a journey into in vitro fertilization. She and her husband were overjoyed when she finally got pregnant. And 9 months later, McCarty gave birth to a beautiful baby girl.
The pregnancy itself was relatively normal. There was nothing, that I out of the ordinary with it, except at 37 weeks, 3 weeks early, my water broke. Ended up going into labor a lot earlier than expected. It's still considered full term at 37 weeks. So, my doctor wasn't overly concerned. And so I recall she came quick and it was like, they actually had to tell me to slow down because the doctor was unavailable. So it was like one of those really funny, you'll always remember, but she was good. Everything was fine. And we were grateful.
However, during the final stage of labor, the placenta did not expel from her uterus, a rare condition called retained placenta.
Unfortunately, the doctor spent about 45 minutes trying to get the placenta out, and she couldn't get it out. And so that is often referred to as retained placenta. And the typical amount of time is 45 minutes to an hour max, that because they don't want you to lose too much blood. And I was losing a lot. And so they basically had to take me to an emergency D&C to remove it surgically. And they essentially swoop it out. I don't want to use the other word, but they take it out. And essentially that can cause trauma to the uterus and obviously to the person who it happens to. And so for me, my recovery was normal, but I had a procedure done. And so a surgery. And so that was an unexpected extra factor of kind of trauma for me.
During this procedure, the doctor dilates the cervix and scrapes tissue from inside the uterus. The D&C was successful, and after she'd fully recovered 16 months later, McCarty resumed IVF treatments, hoping to have a second child. She got pregnant but miscarried. McCarty tried again and again, each time with the pregnancy ending during the first trimester. After 4 losses in just 1 year, she needed answers.
And after that 4th loss, my endocrinologist, who's been in practice for over 30 years, said to me, "I've never seen anything like this. We've thrown the kitchen sink at you. I think you need to see a specialist." And pardon the cliche, but it is true. I mean, they literally did every test. We did every medication, every scenario. And he said, "You need to see a specialist." And I remember saying to him, "I thought you were the specialist. Why am I going somewhere else?"
McCarty made an appointment with a gynecological surgeon who specialized in pelvic reproductive conditions. During her first visit, she told her new doctor about the emergency D&C she had had after the birth of her daughter, and the subsequent ones after each of her 4 miscarriages. The specialist immediately suspected something called Asherman syndrome, a condition where scar tissue forms inside the uterus or cervix. It makes it difficult to get pregnant and increases the chance of miscarriage.
And he said, "It seems to me that if you're not having a cycle and you're also having these losses and, you can't get pregnant and stay pregnant, then we need to do an evaluation." They called it an evaluation hysteroscopy, essentially to determine if there was scarring on the uterus. The plan was if he saw any scarring in the uterus, that he was going to remove it, and that it would also be confirmation that it was Asherman syndrome, which is what he initially thought based on his experience.
Dr. Sigal Klipstein is a reproductive endocrinologist and infertility specialist at Envia Fertility Specialist in Chicago. She says scarring of the uterus can be caused by a number of different things.
Certainly, things like having, a D&C after a miscarriage would increase your risk of Asherman's. Having a pregnancy termination where you did not a medical termination, but a surgical termination, right, with the dilation and curettage also could increase your risk. things like this patient had a retained placenta, probably caused some infection in the uterus. So any kind of infection can cause Asherman's, but any kind of surgery in the uterus, having a C-section could cause Asherman's. So those are the risk factors. So if you have any of those in your history, you are at increased risk, and it might be something to sort of think more highly about checking earlier rather than later. But again, OBGYNs would know which questions to ask and would know who merits an evaluation. This is not an uncommon thing.
In order to diagnose Asherman syndrome, doctors must first evaluate the uterine cavity using a procedure called a hysterosalpingogram. A dye is injected into the uterus, and doctors can see if any part of the fallopian tubes or uterus is blocked.
And oftentimes we can be suspicious of Asherman's that way. And the other way to do it is with an ultrasound where you put saline in the uterus, and that's called a sonohysterogram or a saline infusion ultrasound. And we put saline in the uterus and watch in real-time ultrasound as the uterus expands. And oftentimes with Asherman's, it won't expand fully, or you can see like these bands of scar tissue within the uterus. And if either of those tests are abnormal, then the gold standard to diagnose the Asherman's is something called a hysteroscopy, which is a minor surgical procedure where you put in a lighted telescope into the uterus and watch in real time and see if there's any abnormality. And then you can take care of abnormalities at the time of the surgery with little like micro scissors.
McCarty had to undergo this procedure and was able to watch in real time what was happening inside her uterus.
It's like watching Discovery Channel, but on yourself. So it was eye-opening and also reassuring, because I wanted to have someone say to me, yes, there is a reason why this is happening, versus the unexplained infertility that many women get, which is so frustrating. And, this had been going on for so long. So he got in there and he looked, and sure enough, there was a significant amount of scarring at the fundus, which is at the top of the uterus, and then also in the uterus itself. And he called it kind of web-like scarring, enough where it would prevent implantation from happening, or the implantation would happen, but then it couldn't sustain the pregnancy.
However, removing scars from the uterus doesn't always work. Studies show that scar tissue may reform after the first hysteroscopic resection in 31% of women, and in up to 46% of women after the second one. Unfortunately, McCarty fell into the latter group. She had 3 procedures to remove scar tissue, and finally, after the third procedure, McCarty got lucky.
The 4th time I went in, he essentially said, there's no more scarring. You're stable. Now you can try to go have a baby. And I remember it was like that feeling like a weight lifted off of me. Walked out into the waiting room and I'm like crying with my husband going, please make this possible.
McCarty had 1 remaining embryo to transfer for IVF, but her doctor had to get approval before she could try for a baby one more time.
Of course, there had to be another step because he was doing his due diligence. And he was a wonderful, wonderful man. And I had been with him for almost 10 years of treatment on and off. And so he wanted to make sure, he's like, I'm not retiring until we get you another baby.
Once that transfer was approved, McCarty was able to get pregnant, and this time, stay pregnant.
My son is now 5. It's one of those, I'm so grateful to have this story to tell, but I also feel heartbroken for those women who are still going through this, because it is such a process.
While the process eventually worked for McCarty, some women aren't as fortunate. In rare cases, scarring eats away at the endometrial lining of the uterus, which prevents it from regenerating. Klipstein says that when this happens, nothing can reverse the damage. Women with this rare form of Asherman's will never be able to get pregnant.
In those cases, sometimes they'll need to use a gestational carrier to carry the pregnancy. So there are cases that are severe that are not sort of amenable to surgical treatment, and you're kind of stuck, literally, I guess, stuck. But there are cases in which there's just no way to surgically repair.
Fortunately, Klipstein says that unless a woman is trying to get pregnant, having this condition poses no health risks. However, plenty of women with Asherman's do have symptoms that can include pelvic pain, shorter bleeding periods during their menstrual cycle, or no bleeding at all.
If you're not trying to get pregnant and you have no symptoms, you don't actually need to know about it or fix it. It only is really an issue if you're trying to, obviously, if you have symptoms and it's bothering you, or if you're trying to have a baby. But commonly, women with Asherman's don't have any symptoms at all. And so in a woman who's trying to get pregnant and has Asherman's, you really wouldn't often know this until she was having difficulty getting pregnant and then went for an evaluation to see why she wasn't getting pregnant, and then did one of these tests in order to evaluate her for Asherman's.
But just because a woman has 1 miscarriage doesn't mean she should suspect she has Asherman's.
So typically, Miscarriages are common, 20-25% of cases, of pregnancies miscarry, right? So they're very common. So after one miscarriage, we recommend trying again unless there's some inkling that there's a problem. But after two miscarriages, or certainly after three miscarriages, that sort of medical history warrants an evaluation, and part of that evaluation is one of the uterine cavity.
Obviously, I'm not a medical doctor. I'm just sharing my experience. I think it's so important to ask your doctor about Asherman syndrome, your OB if you're not in fertility treatment, or your endocrinologist if you are, and ask the question, could this recurrent loss that I'm experiencing be Asherman syndrome? Because it is becoming more common. Even if you've had a D&C after a C-section, you could potentially be at risk.
Research has shown that Asherman's occurs in up to 39% of women with recurrent miscarriage. And though less than 1% of women experience 3 or more consecutive losses, Klipstein says all OBGYNs should suspect Asherman's if a patient miscarries more than once. However, that wasn't the standard McCarty experienced, even when going through IVF, which Klipstein says is often when patients find out their diagnosis.
You go through a whole lot of work in order to create embryos to put in the uterus, and you want to make sure that you can make good quality embryos, but the uterus is a very significant part of the equation. And so you would really always want to make sure that the fertile ground is fertile and that the home is a good home for the developing embryos.
Experts at the Fertility and Reproductive Medicine Center at Washington University in St. Louis say that while Asherman's has been categorized as a rare condition, they believe it's underdiagnosed and more common than originally thought.
Actually, I talked to a friend of mine that said she worked with an OB and they don't talk about Asherman's. There are many OBs that either don't know enough about it or they don't bring it up in this situation. If it's becoming more common, then more women need to bring it up if your doctor isn't.
If women are concerned that there might be an issue, they should seek out the care of a specialist, at least for an evaluation or conversation. Certainly, if women have had 2 or 3 miscarriages, they should consider seeing a specialist. And, if women have been trying for a year to get pregnant with no reason why they're not getting pregnant, they should seek care. And in fact, if women are over 35, our recommendation is that they not wait a year, that they wait 6 months before they at least start an evaluation and see if there are any reasons why they might not be pregnant, and start discussing potential treatment options.
McCarty says she doesn't fault her first endocrinologist for failing to diagnose her Asherman's, but wishes she knew it was a risk of procedures like D&Cs.
So there's so many different scenarios. If you've had cervical cancer and you've had surgery, that can impact. So it's very frustrating, for sure.
You can learn more about Asherman syndrome, Lisa McCarty, Dr. Sigal Klipstein, and all of our guests by visiting our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. This segment originally aired in November 2023. Our writer-producer this week is Polly Hansen. Our lead producer is Kristen Farah. Our executive producer is Amira Zaveri. I'm Elizabeth Westfield.
Coming up, will surgery soon be performed in the sky? When In Good Health returns. For many of us, it can be hard to leave work completely at the office. A friend may need financial advice or help with their plumbing, and your professional life makes you the best person for the job. It's usually able to be scheduled for a later date, a slow weekend or lazy Sunday, but not all professionals get this flexibility. For doctors, having to work outside the office usually means an emergency situation that could be the difference between life and death. Dr. Paulo Alves was already working for an airline in Brazil when he experienced his first in-flight event.
I was going to Geneva for a meeting, and then this gentleman, in the middle of the flight, started bleeding profusely from the nose. They came right to my shoulder and woke me up. And then he was only speaking German. And of course, I have difficulty in understanding. I just saw that it was a significant amount of blood. And then he said, tumor, which I believe that in German is also tumor, right? So that's very bad news.
Alves is a trained cardiologist, not an expert in cancer treatment. So while nosebleeds are common on flights due to the dry air, it could be a very different meaning if the tumor was causing it. He managed to stop the bleeding and advised that they divert the plane, but the family refused. The plane made it to Geneva and everyone went their separate ways. For Alves, this would be the first of more than 20 in-flight medical events he'll help with. Though for a time it felt like he was getting paged to help a fellow passenger on every other flight he took, Alves says medical events are fairly infrequent given the sheer number of people flying at one time.
As we are speaking right now, there are around between 1.5 to 2 million people flying. So this is a suspended city, right? So now if you see the number of cases that are happening, medical cases, they are actually a very small fraction of those traveling.
But a small fraction is still a lot of lives. Alves recently published a paper looking at data from 2022 and 2023. It found that in-flight medical events occur about once every 212 flights globally. With more than 3 billion people flying in 2022, that's thousands of passengers having some health issue in the sky. And since there's no way to call an ambulance from 30,000 feet in the air, the cabin crew are trained to help in emergency situations. But as you can imagine, their options are limited.
So they are specifically trained in first aid, meaning bleeding, some ice application, minor trauma, things like that, wound care. And on the other extreme of that, AED and CPR. The resources that we have on board are aimed to stabilize the situation. And then if it is good enough for the remainder of the flight, and if not, then you need to recommend a diversion.
The Federal Aviation Administration mandates certain medical supplies, like first aid kits, are on all U.S. aircrafts, and that the cabin crew are trained for medical emergencies. In fact, Alves played a prominent role in introducing programs in Latin America that are now considered best practices, like having automated external defibrillators on board each flight. Now, he's the Global Medical Director of Aviation Health for MedAir, which provides medical, security, and travel safety support. And though Alves is no stranger to helping during an in-flight emergency, he says he actually shouldn't be the first option.
This situation of calling for a medical volunteer, this is an improvised solution for a problem, right? Because if you think there is a problem, really you are counting on a volunteer to help or not? How often there is a volunteer? If I tell you, okay, there is, in our experience, there is 80% of the times you have a volunteer, right? So if I sell to you, let's say, whatever, product that works 80% of the time, I say, come on, I don't want that. I want something that works 100% of the time.
And even with that 80%, you don't get to choose which type of medical professional will volunteer.
It could be not ideal in a few cases because it could be, with all due respect, could be a dermatologist, could be a psychiatrist, with all due respect to my wife, could be, a pathologist. So who's in charge of this situation? How comfortable they are?
Which is why contacting ground-based medical support, or BGMs, has been adopted as a best practice by most airlines. There are a few different models, but many rely on a third party to provide highly trained emergency physicians who have a specific knowledge of aviation medicine.
So they have an understanding about the impact of the environment into the situation, but again, with a very good foundation in emergency medicine. Because this is what you need to do. In emergency medicine, this is exactly the mindset.
They're not working to treat the underlying condition. Instead, aviation medicine is all about stabilizing the passenger until they can get to the appropriate doctor. And though it doesn't happen often, if they need to divert the plane, the ground-based medical support team is equipped to make that call free of bias. Alves says that's an important distinction from simply relying on a medical volunteer. While that person is a medical professional, they're also a passenger who has a strong personal preference for getting to their destination, which could influence their decision to divert.
Not always a diversion is the best interest of the medical volunteer, because that could ruin their vacation or conference or meeting or whatever. Why so? Because primarily they are just another passenger.
Even Alves, a world-renowned expert in aviation medicine, has felt this dilemma, especially during his first volunteering experience on the way to a conference in Geneva.
At some point, I thought I will divert the flight. However, if I divert my flight, I'm going to miss my connection. I'm going to miss my meeting. That was the only reason for my travel. So just to put in perspective how uncomfortable the situation is for a medical volunteer, because we are caught off guard. We are not in our hospital, we don't have our nurses to help us.
Which is why having a ground-based medical support member making that call is so important. And thankfully, this practice is only getting better as communication technology continues to evolve.
We can only enhance this system. And again, we're going to have, as communication improves, we're going to have video, virtual presence, augmented reality. This is what is coming.
You can find more information about Dr. Paulo Alves and all of our guests on our website, ingoodhealthpodcast.org. For more behind the scenes, follow In Good Health Pod on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.
In Good Health returns in just a moment.
Medical notes this week. Does chronic depression run in the family? Researchers aren't sure why some people have brief episodes while others experience years-long depression. However, new research published in JAMA Network uses a novel MRI technique that could help find some answers. The imaging measured a patient's lifetime accumulation of neuromelanin, which can help them estimate the same levels of dopamine. It reveals that low neuromelanin is related to chronic depression. Young women with brief periods of depression showed normal levels of neuromelanin. Will we ever truly get rid of forever chemicals? These synthetic chemicals are in cooking pans, waterproof clothing, and food packaging. They're hard to remove and destroy once they're in the environment, and our current removal technology is slow and inefficient. Thankfully, a new innovation published in Advanced Materials removes large amounts of forever chemicals from water within minutes, about 100 times faster than commercial filters. Have you taken a deep breath today? Research in the journal Science Advances reveals that sighing can help your lungs work better. The lung's surface is covered in a fluid that reduces surface tension, making them more flexible. It consists of several layers, and a deep sigh is needed from time to time to restore the fluid's correct layering and improve breathing. And finally, a new understanding of video game addiction. New research in JAMA Network Open counters the common belief that video game design is to blame for teen addiction. Researchers discovered that kids who showed depressive symptoms and social issues were more likely to have addicted gaming behaviors. This work reveals an underlying issue that could help guide better treatment strategies. And that's Medical Notes this week. I'm Mayan Vasta Betancourt.
Thank you for joining us this week and every week as we break down the science stories you need to know. You can find all of our past segments and guests on our website at ingoodhealthpodcast.org or wherever you listen to your podcasts. Follow us on Instagram, Facebook, and X for more behind-the-scenes content. Tune in next week for another edition of In Good Health.